Good afternoon, everyone. I would like to introduce you my PhD topic, which is point-of-care devices in the management of illnesses leading to shock. I'm Gabriella. I'm a first-year PhD student working at the emergency department, and my vision is to improve the management of patients with acute illnesses presenting at the ER. And to achieve that, my mission is to contribute to the already existing guidelines. Currently I have two ongoing projects. In the first one, we are investigating the efficacy of rapid molecular assays and whether they are worth using in the diagnosis of septic patients. And in the second one, we'll be examining a viscoelectric method guided therapy in gastrointestinal bleeding patients. So as for my first project, we are investigating the efficacy of rapid molecular assays. We are conducting a meta-analysis on the efficacy. So the topic is important because sepsis is a life-threatening organ dysfunction caused by dysregulated host response infection, and it can be diagnosed when there is an evidence of severe systemic inflammation and the documented or presumed bloodstream infection. There are a lot of cases occurring around the world, causing 11 million deaths each year. So early, and that's why early management is important, because adequate antimicrobials and rapid resuscitation strategies has been shown to be associated with improved outcomes. The gold standard diagnostic method currently is the blood culture for bloodstream infection, but the disadvantage of this method is the long turnaround time, which is around, on average, 72 hours. To resolve this problem, there are already existing rapid molecular assays, which can be classified as for several classes, but also classified as tests performed on blood culture samples or performed on whole blood samples. The latter doesn't require the culturing time, so even less turnaround time can be achieved. Our aim is to investigate the efficacy of these tests, which can be performed on whole blood samples. In the meta-analysis, our clinical question was, what is the diagnostic accuracy of these rapid molecular assays for the bloodstream infection? You can also see the paired formula here we used. And our hypothesis is that these assays' accuracy is non-inferior to the conventional blood culture test. Yes, our clinical implication was to provide a faster diagnosis for septic patients. The systemic search resulted in a high number of articles. We are still in the data extraction and full text selection stage, but we have preliminary results from almost 60 articles. Here on the rock plot, you can see the pool sensitivity and specificity, all dots representing a study, and this blue square indicating the pool sensitivity and specificity. It's from several devices, so it's just a pool the diagnostic measures, and then you can also see it on the side that the sensitivity is pretty low for a diagnostic method. The data can be also shown on a one-dimensional forest plot analysis. I also highlighted the diagnostic measures, and which is significant though is the heterogeneity of the studies, which can have several reasons. And also, I brought another rock plot. We made another rock plot separating the devices, but there are several more articles which can be extracted to each device. They are on the market or off the market already because they realized the low sensitivity. For example, the septic has also a low sensitivity, and it's been off the market already. So this is the progress of the first project. We hopefully finish the data extraction and full text selection by the end of this month, and so this is the progress right now. As for the second project, we are investigating a viscoelectric method, ClotPro, guided therapy at the emergency department, and we are investigating the association of this ClotPro guided therapy with blood products used in mortality of GI bleeding patients. Gastrointestinal bleeding incidence is 32 to 47 per 100,000 population in the USA. And what are the benefits of these methods? They can provide a rapid assessment of coagulation and can facilitate a more accurate targeting of therapy compared to the conventional laboratory tests alone. There are already existing guidelines recommending the usage of this rapid device in trauma patients and in patients with perioperative bleeding, but there is no benefit of the evidence. There is no evidence of the benefit of this method in massive gastrointestinal bleeding, and maybe this benefit from trauma research might be extrapolated also for the gastrointestinal bleeding patients, and our aim is to observe the differences in the management and outcome when using ClotPro. So in our clinical question in this retrospective study, whether the use of ClotPro influences the management of GI bleeding patients in the ER, and you can also see here that PICO will be observing patients with gastrointestinal bleeding, and the intervention will be where ClotPro is performed compared to the patients where the device was not performed. And we would use for outcomes a composite outcome where we would observe further bleeding, which requires red blood cell transfusion, and also 30-day mortality will be observing. For the hypothesis, we have two hypotheses. One of them is whether the use of ClotPro improves the clinical outcome, and whether it optimizes the number of blood products transfused. So our clinical implication is to optimize the allocation of these blood products. So here is a summary of my presentation. The first project is a quite large project, so our planned submission date is September this year, and hopefully we can finish the second project by the end of this year. Thank you for your attention.
For your first project, would this rapid molecular assays also determine sensitivity of the bacteria, or blood culture has to go on and the resistance, antibiotic resistance should be determined by them?
Well, there are molecular assays which are capable of detecting several bacteria-resistant genes, but they are less capable of detecting them than the traditional method. So, yeah, they need improvement.
Thank you.
In that sense.
I understand the sensitivity is still lower, specificity is lower than the standard methods, but do you still see a place for these kits in the clinic? Like, is there a scenario when you think that we should use these over and/or the other methods as well?
In the studies, they use both of them in parallel, and then they compared to each other. And the aim would be to substitute, or so even to have a new gold standard, because also blood culture is the gold standard, but its sensitivity is also a little bit lower than it should be. And as I mentioned, the long turnaround time is also a problem. So.
And how about patients who have received prior antibiotic therapy, for example? Because sometimes that can actually delay even the cultures as well. So it's not 72 hours on average, it can be even longer. Would the rapid kits actually help that scenario?
Yes, in some studies we found that they made a change in the antibiotic therapy based on the result of the rapid test. So maybe there was a study where there was clinical improvement because of the faster result of the rapid test. Thank you for your question.
Thank you for your presentation. It was very interesting. My question is that in the second topic, this ClotPro method can be used only in case of gastrointestinal bleeding, or it can be useful in case of other type of bleeding, like an extrauterine gravidity or bleeding because of trauma?
Yes, the pathophysiology is a little bit different for each bleeding, but it can be used because the aim with this method is not only to observe the prothrombin time and thrombin time, but also have information on the anticoagulant effects and also the anticoagulant factors, and it can affect also not just gastrointestinal bleeding patients, but also other patients as well. So it can be absolutely used in other patients as well.
Okay, thank you.
Thank you for your question.
Can you help me about these rapid assays? They are based on what kind of technology or methods?
Yes, they are different in methodology. Most of them actually uses a PCR technology, or also PCR coupled with an electro ionization or mass spectrometry technology. It depends on the brand.
So it means that they can detect various agents, right?
Either
Okay.
like
How expensive are they?
they are. I can't really recall, but they are almost 10 times more expensive than a blood culture. So they are expensive.
Thank you. And concerning ClotPro, what is the side effect of this?
The side effects.
Side effect of ClotPro?
There is not really. It's only take venous. It's a blood venipuncture. So
No.
it's only one more at the bottle.
Uh-huh.
That's serum, citrate tube.
Thank you. About the second topic, I'm curious. So it's a retrospective observational study. So you saw the data and you worked there, I guess, and you saw those patients. There is a reason why trauma patients has a recommendation to use ClotPro and to give blood products based on that. Because of course of the systemic trauma, there are changes in the coagulation pattern. But here, whole blood is just losing. The patients are just losing whole blood. Of course, if you are losing a lot and diluting it, there can be coagulation problems. But in these patients of yours, do you usually see real coagulation problems which are measured with ClotPro, or what are you anticipating? What will your results look like? What is the change in the ClotPro that you are looking for?
Yes. So with ClotPro, because we have patients at the ER with liver failure patients, for example, or patients taking anticoagulation medicine, and that influences the results. I can't really evaluate these results properly. I saw the figures, what these devices do, but I have to learn how to evaluate them properly. We have a small, we had a small retrospective analysis based on that, and at the ER we are not. So we also have to learn how to use this device because it's pretty new at our department as well.
So your focus is not about gastrointestinal bleeding, but patients who are on having any other comorbid conditions.
Basically, it's just a subgroup of the patients we perform ClotPro. It's just we are just planning to observe these subgroup of patients, but we are performing also for other type of patients, not just.
So why did you choose the gastrointestinal bleeding patient cohort? It's just it's not really connected to the ClotPro results. I mean.
Yes, I can totally agree with that. We just need we just wanted to have a guideline or only a small protocol in our department, and that's why we are planning to observe in these patients.
Thank you.
Thank you for your question.